Namaskar, sir.
Namaste, namaskar.
So, welcome to this episode of Happy Learning Masterclass. And now I request Namaskaram, everyone. We start the program with prayers to the divine. And
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति
Sujya,
Yes, ma'am.
a few lines.
Yeah. So moving forward, it's my honor to be introducing Dr. Asha Jain, ma'am, who's the coordinator of today's program. Ma'am requires no introduction, but a few lines. She's currently the director of SMSA Hospital, Raipur. She's also the medical director of CPRS and the zonal chair Foxy Food Drug and Medical Surgical Committee, West Zone. Previously, she's been the president of Raipur Society and also the vice president of IMA Chhattisgarh. Currently, Madam is standing for the post of chairperson, Food, Drug and Medical Surgical Equipment. So requesting ma'am to please take over.
Thank you, Sujya. Thanks a lot. I would like to introduce my co-convener, Dr. Rijesh Ravi. He's the secretary of Calicut Obstetric Gynec Society. He's the Foxy Quiz Committee coordinator of South Zone, KFOG Academic Committee chairperson, and forum coordinator for KFOG PG Forum. He's the organizing secretary, Foxy South Zone Zonal Conference, co-convener of monthly Badlao series by Foxy Quiz Committee, and Quiz Master conferences. Welcome, Dr. Rijesh. I would also like to introduce my co-coordinators, Dr. Kalpana Ji ma'am, who's an assistant professor at Malabar Medical College and Research Hospital, Madlakalur, Calicut, Kerala. Her areas of interest are high-risk pregnancy and obstetric gynec practice in a meager setup, teaching MBBS and PG students, does a lot of social work. Dr. Sujay Shri, who is the secretary of Bhimavaram Obstetric Gynec Society. She's a consultant obstetrician and laparoscopic surgeon at Seshadri Hospital, Palakol, and Seshadri Hospital, Malikapuram. She has a lot of awards and a very, very dynamic young gynecologist whom we hope to see in Foxy soon. We have Dr. Rekha Rajendra Kumar ma'am, who is the president of Bangalore Society, another very dynamic member associated for long with this series. She's a practicing gynecologist for last 32 years, has organized many things, and she's just organizing a new conference in Bangalore at the end of this month. So welcome all the dignitaries, and I would like to now welcome MC Patel sir to give his formal welcome address to this August gathering. Sir is standing for President Foxy this year, and he has been working for medical legal topics and helping all gynecologists all over India for more than 15 years now. So I will take his formal introduction in the panel, but I welcome you, sir. This is your brainchild, and I invite you to take this forward.
Thank you. Thank you, Asha. It gives me immense pleasure to welcome you all to 196th episode of Happy Learning Masterclass. And today's joining society, Adur, Alappi, Kollam, Kottayam, and Trivandrum. I welcome Dr. V. Rajasekharan sir, who has kindly consented to be guest of honor to bless the webinar. Of course, he is always with us in any of our academic activity. Welcome, sir. From your busy schedule, you have spared time to bless us. Thank you for the same. I also welcome Kunju Mohiddin from Pariyanthal Manna. He is President KFOG. He has also kindly consented to be guest of honor to bless the webinar. I also welcome two learned speakers. One, Dr. C. Nirmala Madam. She is going to discuss very important topic of preeclampsia prevention. What is new concept? And to chair that very important session, I welcome three learned chairperson, Dr. Thanku Thomas Madam from Alappi, Dr. Sujamol Jacob Metham from Trivandrum, and Dr. N.C. Jacob Metham from Kollam. I also welcome one more learned speaker, Dr. B. Prasanna Kumari from Adur, and to chair that very important session, I welcome three chairperson, Dr. Bina Kumari from Kottayam, Dr. N.S. Sridevi Madam. She is President National Study for Trophoblastic Disease in India. I also welcome Nirpin, one more chairperson to chair that very session. And very important panel we are going to conduct. This is counseling and consent in OBGYN practice. And it is reverse panel. Panelists will be asking a question. And being a moderator, I will be answering. So to invite all those learned panelists, I welcome Dr. Cyprus Papachan from Adur, Dr. Lalitambika Madam from Alappi, Dr. Kavitha Madam from Thiruvananthapuram, Dr. Ashanath Madam from Kottayam, Dr. B.C. Binu Madam from Kottayam, Dr. Kumar Gopal from Thiruvananthapuram, Dr. Reji Mohan from Thiruvananthapuram, Regis Ravi from Calicut, Dr. Kalpana Madam from Calicut, Dr. Reena Madam from Kollam, and Dr. Kala Madam from Thiruvananthapuram. I also welcome Dr. Asha Jain. She is convener in this series since long. And to join her, I welcome Dr. Regis. Regis has helped me a lot in this webinar as far as planning of this webinar and execution. So welcome Regis, and thank you for the same. I also welcome three coordinators, Dr. Rekha Rajendra Kumar, President Bengaluru Society. She is a coordinator in this series since long. And Dr. Sujay Sri, she is also in this series since long. She is also helping us in this academic activity. Welcome, Sujay Sri. And I also welcome Dr. Kalpana Madam from Calicut. She has also helped us to coordinate this webinar, and all the president and secretary of joining society and all the delegates who have joined this webinar. In era of COVID-19, I started this series with three friends, and aim was to meet our Foxian friends on virtual ground, to say hello and to focus any topic for discussion. And we were doing that webinar educational series. But with time and on request of so many friends, we continued this series. And now I am happy to announce it is more than 7,000 plus member family as far as Happy Learning Masterclass is concerned. And this is 196th episode of the same series. So without wasting much of your time, I will be handing over straightway to Dr. Asha. Thank you very much.
Ma'am, unmute yourself, ma'am. Dr. Asha, ma'am.
Yeah. Requesting Dr. Rekha. Would you please introduce, sir?
Yeah. Thank you, MC Patel sir, Dr. Asha Jain, for giving me this opportunity. I have been associated with sir since a long time in Happy Learning webinar series, and this time we have selected guest of honor as Dr. B. Rajasekaran sir, who is a very senior obstetrician gynecologist. Sir is the past president of KFOG, that is entire Kerala Federation of Obstetrics and Gynecology. He was the former professor of obstetrics and gynecology in Trivandrum Medical College as well as Calicut, former president of KFOG, as I said, currently liaison officer of KFOG with the government and taking many government projects forward. Like in Kerala, all of us know he is a pioneer state in reducing the maternal mortality, the neonatal morbidity, etc. So, sir is doing many liaison work and strategic work in association with the government regarding that. And sir has finished his MD way back in 1974. Thank you, sir, being so senior and with lot of experience. We are very honored to have you here, and that is our prestige. We would like to hear from you, sir, Rajsekaran, sir. We would like to hear
So
from
thank
you.
you. And thank
Yes.
you all. This is a very auspicious occasion, the 196th edition of Happy Learning Masterclass webinar series. And thank you all for inviting me and honoring me during this very special webinar. And let me take this opportunity to thank Professor MC Patel, the program director, as well as the past president of FOXY, for taking this unique initiative forward to this particular level. And probably this is a classical example of how a scientific program can unite people across various states and myriads of OB/GYN societies in India. So your meticulous planning and great teamwork is helping this webinar series to be on the right track. Thank you, sir, for your keen interest and persistence, which made this as the biggest flagship program of Foxy. And the today's topic selection also seems to be very appropriate, because even though we have been hearing about pre-eclampsia for quite some time, I think the knowledge, the basic knowledge is there are scientific strides, but even now we are groping in the dark. I think Dr. Narbala will be able to clear some of those doubts regarding that. Same is with the placenta creta spectrum. Of late, we are hearing a lot of on placenta creta spectrum, but unfortunately, the ultimate word regarding the appropriate management even now is not very clear. So I think we will listen to these speakers and get appropriate answers. And I wish all the speakers, chairpersons, conveners, and coordinators all the very best, and wish that this happy learning Ashwamedha of Dr. Patel will move on and on, proclaiming unity of Foxy member bodies and reminding us on the necessity to continue our never-ending saga in search of knowledge. And wishing the webinar all success. Let me conclude my words. Jai Hind.
Thank you. Thank you, Rajsekaran sir. You are always
Thank
kind
you.
to us for sparing time to place us in any of our academic activity. Thank you, sir.
Thank you.
Thank you for the same.
Thank you.
Thank you, Rajsekaran, sir, for your good and best of words for us. I'm sure that you have blessings to our contestant, Dr. MC Patel, sir, as well as Dr. Asha Jain, in making them successful in their path. Thank you, sir.
Definitely.
Yes.
200% you can expect.
Yes, sir. Thank you so much for that.
Thank you, sir. Thank you, Dr. Rekha. Now, over to you, Dr. Rajesh, to introduce Dr. Kunjumoiddin, sir.
Good evening, all. It's my pleasure to introduce the president of KFOG, Dr. Kunjumoiddin sir. Sir is the guest of honor for this 196th episode of webinar Happy Learning. And sir is also, as MC Patel sir, Kunjumoiddin sir is also a ardent fan of webinar series and technology in improving the outcome of education as well as togetherness. So Kunjumoiddin sir is the president of KFOG for the year 24-25 and chairperson of Kerala chapter of ISAR, was past Joint Secretary of IFS and Founder President of Perindalmanna OG Society. So I welcome you, sir, for your few words as the guest of honor.
Yes, he is there. He has joined.
Yes, I think sir has logged out. Some problem with net maybe.
So we can do.
We
We
take
can.
the program forward,
and
and when
when
sir
he
joins
joins,
in, we will take his
yes,
words.
yes, we can do.
So, Dr. Rajesh, if you would like to say a few words before we take the program forward. You are muted, sir.
Yeah, as I told, this one of the programs. It has started during the COVID times when the webinars were started. MC Patel sir came with this happy learning program. I think Calicut Society has been associated twice or thrice with this before itself. Has
Right.
been, yeah, twice.
This is
And
fourth time.
it was my pleasure to have been associated with sir as convener also. And being 196 episode of a webinar series, it is such an effort from sir's part and all the coordinators also. And it has taken education to a next level. That is what I believe. Having been able to hear with all the star words from all over India for a long time and many times and repeatedly has of course increased the clinical knowledge of almost all the Foxians. I thank you, sir, for the same, as well as Asha Jain, madam, for the same.
Thank you.
And I
Thank
think with that, we'll move on towards our program.
Thank you so much,
Thank you,
Dr.
Rajesh.
Rajesh.
You are good friend and always ready to be helpful to us in any of our academic activity. Thank you for sparing time and thank you for helping all the way.
My pleasure, sir. Thank you.
So now I would like to introduce our chairpersons. Dr. Thanku Thomas Koshi is an associate professor gynae at Government Medical College, Manjeri, Mallapuram. She is the secretary of Alapuza Obstetric Gynec Society. I hope I'm pronouncing it right. So welcome, Dr. Koshi. I would like you to introduce our speaker. Our second chairperson is Dr. Ansi Jacob. She is consultant gynec endoscopic surgeon, professor in gynae at Travancore Medicity, Kollam. Her interests are endoscopy. She has been trained under Professor B.J. von Herendel and she has many, many publications. So, Dr. Ansi, ma'am.
Yes, ma'am. Very good evening, ma'am.
Good evening. Ma'am is, so our third chairperson is Dr. Sujamul Jacob, ma'am, who's a professor of gynae, Government Medical College, Trivandrum. High-risk obstetrics, ultrasound and Doppler and vaginal surgeries are her forte. And she is also the president of TROGS, past secretary TROGS, PGI examiner of MGMS and DMD. She is the KUHS inspector for Medical College and she has many publications. I would request Dr. Thomas to introduce the speaker, Dr. Nirmala. I would request Dr. Ansi to introduce the topic and requesting Sujamal Jacob ma'am to take the program forward and sum it up. So with this, I invite Dr. Thanku Thomas Koshi to introduce Dr. Nirmala ma'am.
I have great pride in introducing Professor Dr. Nirmala C., an eminent academician and an excellent surgeon who retired as a professor and HOD from the prestigious Government Medical College, Thiruvananthapuram. She is one of the pioneers in the field of medical epidemiology in Kerala. She has a big bunch of national and international publications, both in the field of obstetrics and gynecology and epidemiology, to her credit. Now she is working as a professor and HOD of obstetrics and gynecology in Medical College, Karakoram, Trivandrum. Over to you, Ansi.
Thank you, ma'am. So it's a very relevant topic of the day. And I'm very most privileged to be part of this webinar. It's a most prestigious academic session, which is going on 196 session. So the topic is the preeclampsia prevention. Like we say, it's always prevention is better than cure. And we are all scared of this condition because of its deadly and complications associated. So, or any form of preventive strategies is always welcome regarding preeclampsia prevention. So what are the newer things in the prevention? So to talk about it, the most experienced and senior person and the apt person for that is Madam Nirmala Madam. So over to you, Madam.
Nirmala ma'am. Can we see ma'am?
No, we can't see her.
Yeah.
Yeah.
See, madam. Madam is not unmuted. Yeah.
Okay. Am I audible?
Yes,
Yes.
madam.
Yes,
Yes, madam.
Madam.
Yes, Madam.
Ma'am,
Ah,
ma'am, if you would share your screen, please.
is it visible?
Yes, ma'am, it's
Yes,
visible. You have to make it a big screen, ma'am. If you could just enlarge it.
Okay. Is that visible? Can I
Yeah,
start now?
fine. Ma'am, please start.
Okay. Thank you. Good evening to everyone. MC Patel sir and your whole team. Thank you so much for making me a part of this 196th educational program. And thanks to my colleagues of Trivandrum Ops and Gynae Society, Dr. Sujamon V. Jacob and Dr. Kala, and Tangu, my student, for her beautiful introduction about me. Thank you so much. Now, let's move on to this topic, and I congratulate Patel sir for giving me this particular topic of preventing preeclampsia. This is because we all know that just 22nd of May, theme for this year was predict, prevent, and prevail. That's why this topic is very, very important. And we all know that we, the obstetricians globally, particularly of countries like ours, yes,
Nirmala ma'am, your voice is breaking, ma'am. Ma'am has logged out. Sir? Sir, can we take the second lecture and then
Oh, yes.
get
Oh, yes.
madam's lecture together and take it after this one?
Okay, okay, we can do.
Dr. Rekha, if you would introduce the chairpersons, please.
Yeah, fine. Can I have? Yeah. Thank you, Dr. Asha. It is very nice to introduce the chairpersons here. I'll just open my
I think
screen.
Nirmala madam has logged in again.
Sorry about the network problem.
Yeah, she is logged
Are
in
we
again.
audible now?
Yes, madam.
Yes, Nirmala madam can proceed.
You can open the screen, then we will know, madam.
Okay. Is that visible?
Not yet. Now we can see. Yes,
Am I
yes.
audible now? I think there's some disturbance because of the rain going on. Some disturbance. So I'll continue from where I started. It's on the 22nd May. Was the
Madam, switch off your video and talk.
Ma'am, switch off your video and come near the screen and talk.
Is predict, prevent, and provide. That's why this topic is very, very important. We are striving towards achieving our goal. Okay. Can you hear me?
Yes, ma'am, we can hear you. We can hear you.
Okay. Now let's move on to what is preeclampsia. It's a multi-system. We all know that it's a multi-system disorder, and it's a potentially preventable preventable cause for maternal and fetal mortality and morbidity. Cursor is not moving. Okay. Now, so for all the seniors, knows that we have diagnosed many cases of preeclampsia, but every time the presentation may not be typical, and sometimes we'll be wondering what exactly are we facing with. And there's a lot of every time the definition also keeps on changing, and we don't know what is happening. So now in 2019, this article published in International Journal of Obs and Gynae, where FIGO has come out with an initiative of preeclampsia, and they define preeclampsia. As per the FIGO's preeclampsia definition, there's a hypertension that's occurring at or beyond 20 weeks of gestation. And when this new onset hypertension, which is defined as systolic blood pressure of 140, 90 mm, or a diastolic or equal to or more than 90, systolic of 140 and diastolic of 90 or equal or more than 90 mm, which happens at or beyond 20 weeks of gestation. When this is associated with any of the following three features, you consider it as a preeclampsia. The first is proteinuria. We know the definition, more than 30 milligram per mole, and protein creatinine ratio, or more than or equal to 2 plus dipstick. And then if there is a maternal organ dysfunction, like an acute kidney injury, liver involvement, neurological complications, or hematological complications, or when there is a uteroplacental dysfunction, as evidenced by fetal growth restriction, abnormal umbilical artery Doppler, or stillbirth. If with the hypertension, if any of one or more of these factors, it's defined as a preeclampsia. Now, this is in FIGO in 2019 is classified again preeclampsia into 4 groups. An early onset preeclampsia that happens before 34 weeks of gestation. Actually, this is the type of preeclampsia which is associated with more higher short-term and long-term maternal and perinatal mortality and morbidity. The late onset, which happens after 34 weeks of gestation, preterm preeclampsia and term preeclampsia. This is how it's subclassified into. And when we talk about prevention, the preeclampsia that can be prevented is early onset preeclampsia. Now, why is it important to diagnose an early onset preeclampsia? Newer and newer evidence have come showing that compared to a late onset preeclampsia, early onset preeclampsia, it usually proceeds more aggressively, shows faster deterioration, and is commonly associated with fetal growth restriction, the features that are attributed to early gestation dysfunction of the placenta. Now, what about late onset preeclampsia? Late onset preeclampsia is more associated with the maternal phenotypic characteristics such as obesity, diabetes, or metabolic syndrome, and is presumably less affected by placental dysfunction. And to understand what are the preventive methods, a little bit into the understanding of the pathogenesis of preeclampsia. This pathogenesis is based on the two articles published, one in 2024 in the International Journal of Molecular Science, the other one published in the Journal of Clinical Medicine in July 2020. And based on that, they say it's a current theory suggested two-stage process. One is shallow invasion. As we know that the trophoblastic inadequate remodeling of the spiral arteries, this will lead to the second stage of the disease, where there's an endothelial dysfunction and there's an imbalance between angiogenic and anti-angiogenic factors. This will result in clinical features of the disorder. This was the current understanding. As is shown in all these pictures, the remodeling, which is very familiar picture, it's known to all of us. It has been described in many of the obstetric textbooks. But now the current evidence says that the vascular nutrient adaptation involves more than spiral artery remodeling. Recent evidence has shown that the veins and lymphatic vessels are invaded at an earlier stage than the spiral arteries, illustrating that the adaptation of the uterine circulation involves much more than just the arteries. Now, and the abnormal spiral artery remodeling, which we have been thinking as a cause for the abnormal perfusion, is now considered as a sequence of the abnormal perfusion, the intervillous phase that happens even during the development, the preparation of the endometrium for the SCG. Now, this is a picture showing all that. Now, another factor, this oxidative stress has been described for long. Now they come out with evidence showing that because of the oxidative stress, which triggers an intravascular inflammation and an endothelial dysfunction, that will release a factor such as tumor necrosis factor, interleukin-6, interleukin-10, C-reactive protein, and other factors such as hemoglobin. That's how they are now, this has led to the development of newer biomarkers for early diagnosis of preeclampsia. Now, this picture shows, in short, a two-stage paradigm, but this has now been replaced by the early modeling and the remodeling in the venous and the lymphatic spaces. And this is how the organs are getting affected. Now, another current understanding is the maternal cardiovascular system's contribution, especially in late onset disease. The placentation is normal, but the placenta certainly plays a role in the development of preeclampsia. There's a growing body of evidence that maternal cardiovascular system may have significant contribution to the disorder. Now, let's see what are the preventive and screening preeclampsia available. And this is published in the Journal of Clinical Medicine 2022. And 2019 FIGO also recommends a universal screening. We have been talking about screening for gestational diabetes. First visit, 24 to 28 weeks, HbA1c, all these are used for universal screening. Likewise, FIGO recommends that there has to be a universal screening for preeclampsia as well. And it's called a best combined test. You can use the combined test, which has to be applied to the first antenatal. And the first antenatal visit has to be as early as possible. And this combined test includes maternal risk factors, measurements of mean arterial pressure, serum placental growth factor, and uterine artery pulsatility index. And now, what are the maternal risk factors? We all know this: maternal age, parity, previous history of preeclampsia, pregnancy interval, assisted reproduction, family history of preeclampsia, obesity, race and ethnicity, and comorbidities. And as per the NICE hypertension pregnancy guidelines, the risk factors can be classified as moderate risk factors and high risk factors. Moderate risk factors include nulliparity. That means if a woman comes as a first primigravid, she is a risk for preeclampsia. And suppose she has got initial factors with a pre-existing family history of preeclampsia or an autoimmune disease, she can be considered as a risk for preeclampsia. That is, NICE advocates that women should be considered to be at high risk of developing preeclampsia if they have any one high risk factor. That is a hypertensive disease in previous pregnancy, chronic hypertension, chronic renal disease, diabetes, or autoimmune disease, or any two of more risk factors like nulliparity, age equal to 40 years, BMI 35, family history of preeclampsia, or in the pregnancy interval of more than 10 years. Now, so once you stratify her based on her risk factors based on the history, we need to measure the mean arterial pressure. Mean arterial pressure, which is calculated from the systolic and diastolic blood pressure readings. And this, the Fetal Medicine Foundation has come out with apps for measuring the mean arterial pressure. Now, the third one is the uterine artery pulsatility index. We know that when there's a high pulsatility index, there's an increased chance for development of preeclampsia. Now, coming to this biomarker. So we have been talking about a combined screening where you say first maternal risk factors, then comes your uterine artery pulsatility index and the biomarkers. Various biomarkers has been proposed, but the one that is being followed in UK and other countries is a low resource setting country. Now, other potential urinary biomarkers has also been in the pipeline, but still not been. This article that's published in Molecular Biology Report says that urinary biomarkers are being tested, but they are not available for routine use. Now, what the FIGO says is that if the universal screening is not possible, you cannot use, you can use the history along with the mean arterial pressure and two factors, not the maternal risk factors alone. And if maternal serum pregnancy associated protein is measured for routine first trimester screening for fetal nephropathy, the result can be induced for use for preeclampsia risk assessment. Now, where universal screening with all the four factors are not possible, FIGO states that you can have to do a contingent screening. Where resources are limited, the routine screening for preterm preeclampsia is by maternal risk factors and mean arterial pressure in all pregnancies. And then reserving the measurements of placental growth factor and uterine artery pulsatility index for a subgroup of the population, which is selected on the basis of the risk derived from screening by maternal factors and mean can be considered. So if there is a resources were limited, we can go for this. That's it. It's like a two-stage testing as we have been doing for diabetes. Now, coming to the prophylactic measures. This article that's published in August 17 in the New England Journal of Medicine has made aspirin as a drug of choice for prevention of preterm preeclampsia. And we all know that the aspirin study, which said that the 150 milligrams of aspirin, can you hear me?
No.
Am I audible?
Yes, madam. Yes, you are audible.
Yeah.
You're audible.
Yes, madam.
Started with the 12th week of pregnancy, which has to be given at bedtime. And mechanism of action, we all know that actually if postgraduates, it's for the interest of the postgraduate, this is one common question. What's the mechanism of action of aspirin? It says that the ability to inhibit platelet aggregation and to promote vasodilatation, ultimately improving the blood flow to placenta. But now newer studies have come which shows the role of aspirin in a much better way at the cellular level. Now, this article, which is published in September 22 in Archives of Gynecology and Obstetrics, shown a few new advances in prediction and surveillance of preeclampsia and they use machine learning approaches and remote monitoring. Patient need not come home. Using a machine learning approaches and remote monitoring, we can monitor these women. And these are the 5 interventions that has been proposed and recommended for the prevention of preeclampsia. One is dietary interventions, the calcium and vitamin supplementations, and also they are talking about Mediterranean style diet. Cardiovascular drugs like pravastatin therapy, endothelin receptor antagonists are also on the pipeline, probably due to phase 3 trials are underway. Once the results are out, they may become routine. Other drugs, aspirin, low molecular weight heparin, antioxidants, and magnesium. Then lifestyle approach, reducing stress and working hours, and the role of sports during pregnancy is also being recommended in a big way. And then artificial intelligence has to be included as part of surveillance and screening for early detection. And this forms the new perspectives for the future. Now, what about calcium supplements? We have been talking about aspirin, calcium supplements. And the WHO recommends on the use of calcium in population with a low dietary calcium intake. 1.5 to 2 grams of oral elemental calcium is recommended for pregnant women to reduce the preeclampsia. This is being practiced, but I'm not sure whether this is followed universally and all our pregnant women are getting this or not. Now, in 2014, recommendation by Government of India on the national guidelines, they said total of 1 gram per day, starting from the 14th week of pregnancy up to 6 months postpartum. This is a little, dose is little less than what has been recommended by the WHO. But actually, WHO recommendation came in 2018 and this recommendation 2014. So I think it's better that we go with the WHO recommendation of 1.5. Then the role of vitamin D. Hypovitaminosis D has been associated with an increased risk of preeclampsia. So routine supplementation of vitamin D, but because it's a fat soluble vitamin and some of the effects on this, the fetal brain cells, the dose and other things has not been so far very clear. Now, omega-3 fatty acids. This at 30 milligrams of omega-3 fats and particularly better from a dietary source rather than supplementation. Now, coming to the other novel therapies are the endothelin receptor antagonists. There are so many drugs that have been proposed, but these are the 3 drugs: ambrisentan, bosentan, and macitentan. These are being used for treatment of primary pulmonary hypertension, but this is being proposed for prevention of preeclampsia as well. But phase 2 and 3 trials are on the way. So maybe in another 2-3 years, we may get results. Now, statins. Use of statins has been proposed for preventing preeclampsia, and pravastatin is the drug that's proposed as a potential agent for the prevention of preeclampsia. But the conclusion is that, though promising, these preventive benefits, along with the potential role of statin therapy in the treatment of preeclampsia, must be investigated in larger randomized control trials. This has been done in smaller trials. No, so finally, to conclude, the most important factor, remember, preeclampsia is preventable. As we screen all women for diabetes, please screen for the message is that screen, universal screening. And for those you find this is high risk, you go for a prophylaxis therapy. And thank you. And this is awareness for the May 22nd, 2024. Thank you once again for the patient listening and for allowing me to participate, Patel sir. And sorry for the interruption that has happened. It's raining in my place now. Thank you. So how do
Thank you so much, ma'am.
Over to stop share. Okay, stop share.
Over to Sujamol ma'am to sum up the case, please.
So, thank you, Nirmala madam, for the very clear and crisp presentation on the prevention and preeclampsia. In fact, from this talk, we understand that the key challenge in the prenatal care is to identify those patients who are at high risk for preeclampsia. And in the very early stage itself, from the booking visit, by the risk stratification and the mean arterial pressure, we should be able to identify these patients and start the intervention well early by 12 weeks so that we can either prevent or mitigate the progress of the disease. So the identifying the patient is primarily our responsibility to go ahead with critically evaluating these patients. That's what we understand. And that should be the message that should be conveyed across to all the practicing obstetricians, because we know that this is a multi-system progressive disorder which can damage both the baby as well as the mother. Okay, so how by early measures, especially the early onset preeclampsia, we'll be able to reduce the severity of the disease. That is what which brings about a better outcome. So, Madam Nirmala Madam, it was a very clear presentation. And thank you, Madam, for this wonderful presentation on the prediction and prevention of preeclampsia.
So,
thank you, ma'am.
excellent.
Nirmala ma'am, there is one question. So just a second. There is one question, Nirmala ma'am. On YouTube, Dr. Geetanjali Katagiri has asked if low molecular weight heparin is started for suspected APLA, what should the dose of aspirin be? 75 milligram or 150 milligram?
So currently, the recommendation is 150. It has to be started from 12th week onwards. Actually, best in window period is 11 to 13 weeks plus 6 days, where we screen for just like the NT. That's the best time to start, and it has to be continued at bedtime till 36 weeks of pregnancy or whenever you plan to terminate the pregnancy. That's the current recommendation.
Okay. Thank you, ma'am. Actually, that was the question in the chat box, so I had to ask. Thank you for answering that.
Excellent, Dr. Nirmala Madam. And you have very meticulously taken the subject as far as prevention part is concerned. And as I go with my area, as far as litigation part is concerned, usually in pre-eclampsia or even in few of the cases of eclampsia, when litigation happens, usually first questions comes in court, was it preventable? And usually you cannot say no, because all complications are preventable. So one more question comes, what did you do to prevent it? So if you have tried to prevent preeclampsia, if you have tried to prevent hypertensive disorders in pregnancy, and if you can prove from your document, then it becomes a good defense in our favor. So this lecture would be very useful that way also, how to prevent as far as preeclampsia and hypertensive disorders in pregnancy is concerned. Congratulations, madam, again. Thank you.
Thank you, sir. Thank you for the opportunity.
Dr. Nirmala?
Yes, ma'am.
Congratulations. It was so crisp and clear.
Thank you, ma'am.
Doubt, no. This aspirin we give to all high-risk women after screening. What about low molecular weight heparin?
Actually, there's controversy
negative.
Low molecular
negative.
Yeah, that's why I didn't go for that, because there are specific indications for low molecular weight. The point I wanted to bring is that screen, always, universal screen. Every woman is a potential candidate for preeclampsia. And we can, UK and all, there's a marked reduction in severe preeclampsia and early onset preeclampsia once they start that aspirin prophylaxis and placental growth factor screening they are using. But our side, how much it's practicable, we don't know.
No. What I ask is when to give this low molecular weight heparin. If she is APLA negative, should we give?
No. If there's a previous.
He has a history of early onset severe preeclampsia, abortions, VOH, typical. But she will be APLA negative. We are giving.
That's why there are atypical types of presentation preeclampsia. But if she had a previous preeclampsia, we are sure that she'll go for early preeclampsia now. So that's where the.
It's better to give, isn't it? We are giving.
Yeah, low molecular weight heparin.
Another thing is we have to screen for this sickle cell disease also, especially tribals. It's very
Yeah,
important. Otherwise,
I didn't go, lack of time, I didn't go for all the
it's a
comorbidities.
very important point.
Which are risk factors. Thank you for bringing that point.
Thank you so much, ma'am. Thank you. And over to you, Dr. Rekha. Rekha, ma'am. You're muted. You're muted.
Yes, yes. Thank you. You want me to introduce the second for the second talk? Okay, fine.
Yes, ma'am.
Yeah, thank you, Dr. Asha. We have 3 chairpersons for the second talk, and the second talk is on placenta increta, the management of placenta increta by Dr. Prasanna Kumari. We have 3 eminent personalities here chairing the session. It's my pleasure to invite the first chairperson, Dr. Beena Kumari Madam. Madam is the professor and head of the department of our own specialty in Government Medical College, Kottayam, President of Kottayam OBG Society, State Coordinator, Medical Education Committee of FOXI 22 to 23. She is a trainer in PPMD for prevention of maternal mortality, also an organizing convener of all Kerala Association of Obstetrics and Gynecology Conference in 2020. Also, UG and PG examiner as well as academically, madam has accomplished a lot. She has her area of interest as high-risk pregnancy and vaginal surgery. Beena, madam, thank you so much for chairing the session and accepting our invitation. We heartily welcome you here to chair the session.
Thank you, ma'am.
Yeah, thank you. Another senior person, Madam Sridevi. Madam is a very cherishing person all the time, smile on face and very comfortable personality. Madam is a Professor Emeritus from Pushpagiri Institute of Medical Sciences, Tiruvalla, Kerala, past President of Calicut Society, past President of KFOG, All Kerala Federation of Obstetrics and Gynecology. Thank you, madam. You are such a senior person. In spite of that, you're obliged to join us as chairing the session here. We are extremely honored to have you. And third young person, Dr. Nirpin Cletus, sir. Hello, sir. We are happy to have you here. He is the consultant obstetrician gynecologist and an endoscopic surgeon in Lifeline Hospital, Adur, MBBS from Pushpagiri Institute of Medical Sciences, Tiruvalla, Kerala, MS from the Government TD Medical College, Alappuzha, Kerala, has presented papers in state conferences. He also has a credit of bagging the first prize for poster presentation twice Kerala conference, publications in lot of journals, including international ones. His interest lies in, again, laparoscopy and high-risk obstetrics. Thanks all the chairpersons. Request Dr. Beena Kumari Madam to introduce Dr. Prasanna Kumari Madam as a speaker, Dr. Sridevi Madam to give us some insight into the topic of placenta increta, and Dr. Nirpin Cletus to conclude the session and give us some take-home message. Thank you all the chairpersons. The floor is yours.
Thank you, Rekha madam. Am I audible?
Yeah, very much,
Yes.
madam.
I am very much privileged to introduce Dr. B. Prasanna Kumari madam. He's a great academician and a very learned teacher for so many students like us. She was the head of the department. She is the head of the department and senior consultant at Lifeline Hospital, Adur. She was a consultant obstetrician and gynecologist, SUT Hospital, Trivandrum, and also the former professor, Government Medical College, Calicut and Trivandrum. She has authored the textbook of postgraduate gynecology, which is a very, it's like a reference textbook. And she was awarded WHO Fellowship 1991. And she again has led the KFOG, the Kerala Federation of Obstetrics and Gynecology, as president. Welcome, madam, and the podium is yours for the presentations. Thank you.
Thank you, Dr. Beena, for the pleasant introduction. Let me thank Dr. MC Patel, Dr. Asha Jain, and Dr. Rekha Rajendra Kumar, because they are spreading knowledge and they are uniting gynecologists of India together. Thanks to Dr. MC Patel, thanks to Zoom, and thanks to COVID. Because of COVID only we are seeing each other. Otherwise, we don't usually see gynecologists from other states. We don't usually see. We meet only in national conferences. So I have great appreciation for Professor M.C. Patel for the introduction of these seminars, spreading knowledge as well as uniting gynecologists in a single platform. Thank you, sir. Let me share my screen. I hope the videos will work because I have only videos to this one.
I think Sridevi Madam was supposed to give an introduction to the topic.
Sridevi Madam, topic introduction.
Was not informed.
Madam, please go ahead, Sridevi.
Hello, can you hear me?
Hello.
Yes,
Hello?
yes, madam. We can
Yes.
hear you.
Very happy to be associated with this wonderful seminar. And the topic of placenta accreta, close to Prasanna Madam's heart. Placenta increta,
No, it's nothing.
accreta. We usually see these situations, and sometimes I have also done so many surgeries at Calicut and even in Pushpagiri Medical College also. And very often what happens is it may be diagnosed only during cesarean, but nowadays, because of the availability of ultrasound and Doppler evaluation, all these things, we are able to identify it very early. And sometimes the patient may present with minimal vaginal bleeding also. So we are always worried about, and we become so much upset when we see such cases and manage it. And we have to keep ready plenty of blood components and planning for surgery. The surgery to be proceeded with is usually we go for a classical cesarean section, delivery of the fetus and hysterectomy. And on to you, Placenta Madam, for the wonderful presentation. We are waiting for it.
Hello, ഞാൻ ഇരിക്കുന്നതിന്റെ പുറകിലത്തെ ലൈറ്റ് ഒന്ന് ഓൺ ചെയ്യണേ. ലൈറ്റുകൾ ഞാൻ ഇരിക്കുന്നതിന്റെ പുറകിലത്തെ ലൈറ്റ് ഒന്ന് ഓൺ ചെയ്യണേന്ന്. Coming to placenta increta management. This is a placenta which was actually previa increta, but spreading almost the whole of the uterus. And she had IVF. So IVF is one thing which increases the incidence of placenta increta. It's what I feel. Because maybe some procedures before IVF, like endometrial coring, etc. I will come to. Just an introduction. It's an abnormal trophoblastic invasion into the myometrium. And as Dr. Sridevi said, it's a life-threatening and usually requires a hysterectomy. And previously, when we used to gather for, Dr. Sridevi may be remembering, for CRMD, we used to get so many cases of placenta increta who had subtotal hysterectomy and then collection inside the abdomen and then relaparotomy and death. So many deaths. And nowadays, it is much, much less. It is almost nil nowadays. Isn't it, Sridevi Madam?
Yes, yes.
Otherwise, we used to see in one CRMD, it is every 3 months, we used to see so many, maybe some 5 or 6 deaths due to placenta increta. So FIGO is classified into grade 1 abnormally adherent placenta accreta, and grade 2 when it invades the myometrium, and grade 3 is into the myometrium, coming out of the myometrium, and that has been again divided into grade 3A limited to the uterine serosa. 3B, it denotes the urinary bladder, rare. It is 10% of placenta increta. These three together. Grade 3C with invasion into other pelvic tissues or organs. So when it comes percreta into the pelvic tissue, it is very, very dangerous. Into the urinary bladder, you may injure the urinary bladder and you can switch her. But into the pelvic tissues, it's very dangerous because it will be very difficult to control the hemorrhage. It's actually a spectrum. You can't classify as 1, 2, 3 and put it in 2, 3 compartments. It's actually a spectrum from a normal placenta to removal. It may need removal piecemeal, but unable to remove because of the adherence, completely adherent. Then abnormally invasive into the myometrium, then breaching the uterine serosa, reaching the serosa, breaching the serosa, and invasion into the bladder wall or the rectum. When you call it percurita. So these are all the pictures of ingrita which we dealt with. And this one, we have done a conservative surgery. And this we did hysterectomy. And even percuritas do not all look the same. Sometimes it may be 3/4 anterior. Sometimes it will be completely ingrita. Sometimes it will be posterior. So it can be different. These are the risk factors, as I already mentioned, prior uterine surgery, previous cesarean, prior surgical termination, curating the endometrium, conception by IVF. I think it may be because the coring of the endometrium, or some way you destroy the endometrium, and advanced maternal age and multiparity. The management, the outcome of the management depends upon accurate prenatal diagnosis. And previously, we used to get surprises on the table with placenta ingrita. Sometimes, you know, the fundal placenta, the placenta ingrita previa ingrita can be diagnosed as fundal placenta if you tilt the probe upside down. So we have seen such situations. So accurate prenatal diagnosis and planning. And for this, ultrasound is the best. I think ultrasound is the best. And if planning for, if you need, especially posterior placenta, if you need to have MRI, it's better to do it at 20 weeks or before that, because it's very difficult to lie down still in the MRI machine with a big tummy. Even without a tummy, I found it very difficult when I had an MRI for my shoulder pain. So it's criminal, no, so to subject the patient to MRI with a full, a term pregnancy. So if you need MRI for diagnosis, it should be diagnosed early by ultrasound, and MRI should be done, if possible, before 20 weeks. And recently, there is a placenta accreta scoring system, which has been endorsed by FIGO and American College. And it helps in, it is based on history of previous cesarean, placental and cervical morphology, and ultrasound findings. And score of 5 to 10 for placenta accreta or ingrita. If the score is more than 10, it may be percreta. But I think rather than the score, the familiarity with the ultrasound findings is important. Obstetrician should be familiar with the ultrasound findings of ingrita in placenta previa. And we have to look for it, especially if she is a case of previous cesarean. And the sensitivity of ultrasound is 90% and specificity of 96%. Both TAS and TVS are to be studied. TVS accurately defines the relation of placenta to the internal os and the bladder. And it helps us in a focused evaluation of placenta bladder interface. And it can be diagnosed very early. See the cervical canal, that is the uterine cavity, and this is the pregnancy in the scar. We actually terminated this pregnancy. We did hysteroscopic evacuation, this scar, this pregnancy. Or else it will become either a scar pregnancy or a placenta previa with ingrita, which we cannot predict. If it is an anterior implantation, it can become a scar pregnancy or ingrita. It is a posterior implantation, the chance is lesser. And it can be diagnosed in the first trimester and anticipated. Coming to the ultrasound features, the most important is the loss of clear zone between the placenta and the myometrium, and multiple placental lacunae, the moth-eaten appearance, myometrial thinning, loss of disruption of bladder line, placental bulge into the bladder, exophytic mass into the bladder, abnormal utrovesical vascularity, and bridging vessels. If you see bridging vessels, it's definite that it's invading the bladder. So that is the placenta. See, that's a central placenta previa. And here the myometrial interface is very less. The myometrium is thin and the anechoic area is much less. And here, that is the bridging vessel between the bladder wall and the placenta. Lot of vascularity and bridging vessels. And here, this shows the placental lacunae, lot of lacunae. You have to anticipate. These are all vessels. See the bridging vessels also into the bladder. So with this, we have to be prepared. So this here, the placenta is going posteriorly, and that is the operated specimen. I mean, this picture taken during the same patient's surgery. That is the MRI finding. Again, bulging and this MRI, it's not ours. It's bulging into the myometrium. Coming to management, there are so many management strategies, so many papers. Conservative management, where the goal is to reduce surgical mobility and fertility sparing. 20 to 50% may need hysterectomy. That's the problem. And risk for bleeding and infection, sepsis. 50% will go for sepsis. And delayed, we may have to do a hysterectomy. So you deliver the uterus and keep the placenta there without touching, close the uterus and close the abdomen and wait. But the thing is, it can be done in centers where you have all the facilities, all specialists and blood transfusion facilities, very good ICU, and the patient should be well informed and patient should be compliant. Then uterine sparing surgeries, where the goal is to reduce surgical mobility, focal myometrial resection and repair. And we have done two. If it is a focal, then we can go for the focal myometrial resection and repair. I don't know whether it is, if it is completely invading into the posterior myometrium as well. I don't know how the sparing uterus sparing surgery can be done. And there are papers from St. George's Hospital saying that they are doing uterus sparing surgery for almost all the cases of placenta previa in Crete. I think it may not be possible in all cases. And then the usual one is cesarean hysterectomy. That's a definitive treatment, but we should be careful not to injure the ureter. And if at all you injure the bladder, you have to suture. For this, as I have already said, expectant management requires long and close follow-up and 40 to 50% risk of serious mobility, bleeding, infection, fistula formation. 58% risk of secondary hysterectomy. And high risk of recurrence of pus in the next pregnancy. That is a disadvantage of this expectant management. One of the greatest disadvantages. So, pre-operative preparation is very, very important. It should be a multidisciplinary team. You should have a hematologist, intensivist, urologist, and surgeon. And especially correct anemia prior to surgery. The patient is anemic and bleeding, you can imagine. So always when you find that the placenta is previa, see that the patient's anemia is corrected and her hemoglobin is ideally 13 gram%. And antenatal corticosteroids she can give if she has recurrent bleeding. And if it is completely in Crete, she may not bleed. So you have to give prophylactically antenatal corticosteroids of 30 weeks or so. And if you are deciding termination of 34 weeks, After 34 weeks, it's not recommended, but before 34 weeks, we have to give. She may bleed sometimes. There should be informed consent for hysterectomy because that's the management. So the family should be informed that hysterectomy should be done. May have to be done. And another thing is, in CRMD, I have seen 2 cases where the patient was diagnosed to have placenta previa with ingrita, and she was sent home with advice to have surgery, cesarean hysterectomy. But night she went to the toilet and she fell down, collapsed and died. And that might have been perquita bleeding into the petroral cavity. There were 2 deaths like that. And I have managed one patient where, the patient had pain and I anticipated that it could be perquita. And we opened the abdomen and the uterus was covered with a sheet of blood clot. A sheet of blood clot covering the entire uterus. And the clot was removed after telling the anesthetist and arranging sufficient blood from the blood bank. They already arranged. The clot was removed and she had cesarean. Fortunately, we got the baby and the mother, she had hysterectomy. So you have to anticipate, you have to tell the family beforehand that she should be carefully monitored, watched. And delivery should be planned by the multidisciplinary team and arrange blood and blood products. Ureteral stents, ideal to have ureteral stents. And it is ideal to deliver it, all guidelines say it's ideal to deliver at 34 to 36 weeks before she lands up as an emergency. Because Dr. MC Patel is there, I tell you one example. While working as professor, I was asked to give a comment on by the police, initial inquiry against a doctor who single-handedly managed a placenta previa, maybe might have been ingrita, and he called the surgeon and night she managed, and both ureters were dilated, thinking that it is intended, and she died. So that was the only instance in my life when I talked against a doctor. Otherwise, I will try my maximum to help doctors. So it should not be dealt with like that. It should be dealt by an experienced person. So there are so many measures to reduce intraoperative blood loss. Blood loss is the problem, no? So there are so many measures, so many papers on embolization of bilateral uterine artery, embolization of internal iliac artery, aortic balloon. The catheter is placed beforehand, and then the balloon is inflated after baby delivery. And then after baby delivery, you can put the aortic clamp device by Pylisa or bilateral internal iliac artery ligation. And this aortic clamp is widely used throughout Kerala. And those who use it say that blood loss is less after using aortic clamp. But my personal opinion is bilateral internal iliac ligation is good because that will control the bleeding in the pelvis, from the pelvis, and the ligature will be there. And if it is aortic clamp or aortic balloon, you will remove the balloon. So there can be reactionary hemorrhage. So I think bilateral internal iliac artery ligation is better. And I think it's better because that I will tell you afterwards at the end if there is time. So the most important part of the cesarean hysterectomy is bladder dissection, because it is the previa that is bleeding, and if the placenta has reached the peritoneum, there will be a lot of small vessels, and the vessel walls will be very thin, and she can bleed profusely from those vessels. So bladder dissection is very important. And I think our method is, before going for to start hysterectomy, we dissect the bladder down, well down below the placenta. And if she bleeds, we'll go for internal iliac ligation and keeping the uterus antivertation. And there are so many centers doing aortic balloon, embolization, and I told you about the aortic clamp, which Pylisa devised. So this bladder dissection is very important, And Dr. Nirpin has assisted me in so many cases, and you should be extremely gentle. And I used to tell them, don't touch, because if you are with little bit, if you rush a little bit, or you can injure the vessels and can cause bleeding. And when you coagulate, you catch the vessel, lift it up, and coagulate what is necessary. If you coagulate more, you'll coagulate the uterine serosa, and the placenta will be exposed, and she'll bleed profusely. So it's better, it should be done very gently. That is the method by which we are reducing blood loss. And so you go in small steps. That is for the beginners I'm showing. You go in small steps gently, and if the vessel is bleeding, you coagulate that also gently. And if you coagulate more, you'll coagulate the uterine serosa, expose the placenta, and that will result in bleeding. So that is the placenta, and the bladder completely dissected down, so that when you come down through our hysterectomy, we can finish the lower part fast, so that you will not bleed much. That is our method. The Pelosi technique, Pelosi also describes such peritoneal dissection early, anteriorly as well as posteriorly. We don't dissect posteriorly early. We dissect the bladder down and then proceed for hysterectomy, so that when you come down in the bleeding area, it can be dealt with fast, reducing the bleeding. So that is a specimen. This is the whole placenta, and that is the suction bottle with 700 ml blood. That is our paper in European Journal of Medicine. Of 19 cases we published, and our blood loss was 1.1 plus or minus 100 ml. So we never had massive blood loss. And we had one patient with massive blood loss. That was actually not placenta previa. That was a cervical pregnancy, which we advised termination at 8 weeks, and we posted for termination at 8 weeks. She didn't turn up. In 16 weeks, we definitely said, if you don't do termination, we won't let you here. And even then, the husband and the wife were very adamant that they will not terminate. They said they will arrange so many bottles of blood, whatever is needed. And she needed 120 pints. And it was actually a cervical pregnancy. It was not a placenta previa. So we did conservative surgery for 2 patients. And this was planned by ultrasound. See the ultrasound, this area only, it is in Greta. Here you see the anechoic area. Here also the anechoic area is very clear. And here up to some 6 centimeters, it's not clear. So we plan for segmental resection of the placenta. So we usually, as everybody else, we usually go through a vertical incision and a classical cesarean, deliver the placenta and wait for placental separation. And sometimes, even if the vascularity is there, the placenta will come out. We have one or two occasions where we could, the placenta came out. We suspected previa in Greta, but placenta came out. Here, see the bladder dissection and that area. This patient's picture I have already shown, very big vessels. And the bladder was dissected, and that is the area of placental invasion of the lower segment. And that only that area was resected along with the placenta. And the uterus was reconstructed. But blood loss was some 1,100 or something, not much. But the increta portion, see that is the muscle with the increta placenta. That is the muscle with the increta, uterine muscle with the increta placenta and the entire placenta. And the uterus was reconstructed. So if it is a segment, that is the final picture of the surgery. That is the blood loss. So we have had 6 cases of upper segment placenta ingrata, which were not diagnosed in the antenatal period, and we managed it conservatively. That is the patient who had a twin delivery, and you can see the cord. One placenta came out and the other did not. And this is the placenta bulging seen through the cirrhosis of the uterus. And Dr. Nirpinulli assisted. We resected that area. See the placenta and the myometrium. Actually, in one case, in the first case, we did know she was a twin pregnancy conceived by IVF. Both babies were moribund, and we had to do a cesarean section at 29 weeks for PPROM with infection, and one placenta came out, and the other placenta was completely into the upper segment of the uterus, and almost half of the myometrium was resected and then reconstructed. She had the next pregnancy by IVF, and 34 weeks because of PROM, and in view of previous segmental resection, cesarean section was done, and baby was okay. And the subsequent IVF was done by one of our students, Baiju, Keto, Sridevi madam. But
yes.
we did the IVF the next time. And 34 weeks cesarean was done, and the child is 8 years old, and recently the child's prayer song was sent to me on on his birthday. So that is how we reconstruct the uterus. It can be nicely reconstructed, and the subsequent cesareans, the uterus will be looking absolutely normal. Post-operative care is important. It's ideal to keep a drain and thromboprophylaxis. Do not forget about thromboprophylaxis. And the patient needs a lot of counseling, and the specimen should be shown to the patient and the relatives. And if she is anemic, you have to give blood transfusion. We gave blood for only 2 patients. To conclude, avoid first cesarean delivery. So that, see, the incidence of this placenta previa ingrata in India is estimated to be 0.9 per 1,000 deliveries, an alarming increase. And in China, it is 0.2%. So it is much, much more. So PAS is increasing because of the increase in cesarean section. And to reduce cesarean section, we have to reduce induction. Avoid surprise, screen antenatally. Risk of under and over diagnosis. If you overdiagnose, it's okay. But if you underdiagnose, it's dangerous. If suspicious, ask for second opinion. And the planning of delivery is very, very important. And the center where it is being done also is important. And the team, of course. So thank you. Everybody is left off?
No.
Everybody is there, ma'am. Everybody is there.
They're all here.
Dr. Cletus, if you would like to say something, ma'am, please stop sharing. Thank you so much, ma'am.
Is Nirpin there?
Now, requesting one of the other present chairpersons to sum up, please.
Prasanna ma'am, that was an excellent presentation. We are always eager to see your surgeries, how you manage, and regarding the conservative surgical management, excellent. But in Medical College Kottayam, we are routinely using iota clamp. We rarely give even blood transfusion because the anesthesia people insist that at least one blood should be ready. So
that is why we also did gave 2.2.
Because just because it is, otherwise it
doesn't
is
need
not
blood transfusion
needed.
at all.
Yeah, that's it. And as you said, after using all these iota clamp, which I am so much used because we don't usually do the internal ligation, and the use of iota clamp is even much easier also, I think. The bladder dissection is again excellent. There's not much of bleeding in it at all. So it was an excellent presentation. There are different methods now. I have not done much of conservative surgical management. I think after I got like motivated by your surgery, I would also like to
go for
all of you can do conservative surgery, both upper segment as well as lower segment. Upper segment, they won't bleed at all. And they conceive again, and the uterus is looking absolutely normal in subsequent.
Definitely, you are a motivator, and I think we will continue with the. We will try with a few of cases with the conservative management. Excellent presentation, madam. Thank you. Thank you so much.
Good.
Excellent presentation, Prasanna madam. I have to well, and all the videos were wonderful. And this Acreta spectrum, now the incidence is increasing, but what we are getting, the number of cases are much less in our hospital nowadays. Used to do many cases there, and actually more of cases I have done in Calicut Medical College and in
more cases I also did in Medical College. This
Medical
one 19 I did in Lifeline after retirement.
Yeah. Many cases were done in Calicut and in Baby Memorial Hospital.
Nirpin is not there. Nirpin used to assist me.
Prasanna, it was a wonderful presentation.
Thank you,
actually, all your videos, instills confidence.
Excellent.
It just gives videos. It speaks for itself. So much. Thank you so much, ma'am.
Thank you so much. And so we have Patel sir.
Yes.
We have 1 hour for the panel.
Oh yes, okay. We can proceed.
So welcome everyone to this panel on consent in the Indian context. And Sujeshri, I would request you to introduce sir.
Yeah. Dr. MC Patel, sir, he's a consultant obstetrician gynecologist at Medical Legal Counselor. He's also been the vice president in the year 2018. He's been the organizing secretary at AICOG 2017. He's also been the chairperson of Ethics and Medical Legal Committee for FOXI in the year 2011 to 2013. So, sir is also an honorary member of National Inspection and Monitoring Committee, PNTT, and also for the Government of India in 2015. He has numerous posts to his credit. So I request sir to please introduce the panelists for this session.
Over to Dr. Asha.
Asha, okay. Ma'am, please.
Thank you. So we proceed with the panel, and that's me. I coordinate the panel. And before we proceed further, here is a short video from sir for his election request.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
respected seniors and dear colleagues, serving Foxy for years together on this auspicious day. With folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ,
ये पहली
आगे
पहेली
है
से।
बढ़ते जाना.
So here are our panelists, and I will be introducing them as the questions come along. But before we start the panel, sir, I would like to ask you a basic question. Is this topic worth discussing? Why do we want to discuss consent? Everyone is taking consent, so is it worth discussing?
Yes, it is very worth discussing because I would like to mention one case, C. Jaipal Reddy versus Padmini Velluri, and this case was decided in National Commission. And in National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is an important document of your counseling, important document of your communication. So whatever you counsel, whatever you communicate, each and every point should be mentioned in that very paper, and then patient and patient party has to sign. So this is very important case. And one more case happened, Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And in that very case, Supreme Court came up with guideline. What should be the ideal consent in Indian context? And accordingly, court expects us to take consent from each and every patient in any procedure, in any surgery, or in your treatment plan also. So consent is very much required. Without consent of any patient, do any surgery, it becomes a crime under section 340 of Indian Penal Code, and you may invite a case of assault or battery under Indian Penal Code. So without consent, one cannot operate, one cannot do any procedure which is invasive. So consent is very much required.
So, sir, now I would like to introduce Dr. Siriak Papachan. He's a world record holder for largest multiple fibroid uterus ever removed by laparoscopy. He's done more than 15,000 gynec endoscopic surgeries. He's a national operating faculty, and he's won first prize in infertility segment at AAGL Mumbai. So, welcome, Dr. Papachan. I hope you are there. If not, requesting anyone present over here to please take the question.
Is anybody from Adur?
Anyone can take it. Dr.
then
Rajesh or Dr. Sujaya, anyone, please take it.
So I would like to start then. So it was question raised by Dr. Sirek Papachan, and it is regarding what is the difference between agreement, contract, and consent. What exactly is this agreement? What exactly is this contract, and what is consent? What is this difference, and what is importance in medical field, sir?
When two or more than two persons agreed upon something in a same sense is agreement. And when agreement is foreseeable by law, then it becomes a contract. Say, for example, today, Regis and myself decide to go for picture, movie. And for any reason, if I cannot go, then it is a breach of agreement, but it has no legal value. But when it is foreseeable by law, then it becomes a contract. And in our medical practice, when any patient comes to us, and once we accept her to treat, it becomes a contract or implied contract between patient and ourselves. We offer our expert services, patient pays for that, or patient promises to pay for that. So it becomes a contract under uh, uh, Indian Contract Act. And exactly as far as consent under Indian Contract Act is concerned. So when two or more than two persons say in the same direction, then it is said that consent is given. So all the parties should be convinced as far as
కానీ
uh,
అర్థం అవుతుంది ఎటు కాకుండా ఉంటుంది
meaning of that very consent.
నువ్వు ఒకసారి చూడు నేను వచ్చేస్తున్నాను ఒకసారి శంకర్కి
I think there is something background voice.
Please mute yourself. Anyone who's not speaking, please mute yourself. Yes, sir, please proceed.
So as far as contract is concerned, two or more persons are said to consent, rather consent, when they agree upon the same thing in a same sense. So when we take consent for patient, it is understood or it is accepted from law that whatever written in that very consent paper was explained to the patient and patient had understood that, and then after patient has signed the document. So this is important of consent in our medical field.
Okay, so
Lalitambika ma'am is the president of Alepi Society. She gave me her inability to join. So requesting someone, please take this question.
Shall I take this up, ma'am?
Yes, Dr. Kavita, please proceed.
The questions are, what is valid consent? What are the criteria for consent to be valid? Who can give a consent? Can a minor give consent for examination? And can she give consent for surgery or procedure?
So what is valid consent? Just I mentioned case of Samira Kohli versus Prabha Manchanda. That very case, it was decided in 2008. Supreme Court came up with some criteria for any consent to be valid in Indian Constitution. First criteria is competence. Who can give consent? Was the first criteria. So any major patient who is mentally sound can give consent on her behalf. Nobody else can give consent on her behalf. So if patient is major, if patient is mentally sound, consent paper should be signed by patient only. Others are witnesses only. Relative, when they sign as a witness, there should be two witnesses, one in favor of patient, one in favor of hospital. So witnesses are witnesses only. They have nothing to do with the content of consent. Witness means whatever written above was explained to patient and patient has understood, and then after, before us, patient had signed the document. So role of witness is there only. So this is one criteria. One more criteria is consent should be voluntary. There should not be any coercion, no force, nothing. Patient should be free to give consent. Third point, consent should be informed one. Patient should have knowledge about your treatment plan, about your procedure, about your surgery, with all its benefits and side effects, and probable outcome, probable prognosis. We have to explain all this. We have to explain about success rate also. At our hospital, in our city, in our state, and in country. So this is also expected from law. As far as other criteria are concerned, There should not be any force. It should be informed. It's fine, and it should be written on. There are some conditions. It is compulsory or mandatory for written consent. Otherwise, we may go with oral also, but it is always advisable because patient may go hostile in court. We were never explained. We never gave consent. So it is always better to go for written one. These are some criteria: competence and voluntary, informed consent, etc. And as far as minor part is concerned, if patient is minor, but if she is more than 12 years, even if she is minor, then also she can give consent for examination. Because in eye of law, she is considered matured minor. So, say for example, if she is a victim of sexual offense, and if she is brought or she comes to us for examination, she can give consent for examination. But in this situation, if surgical intervention is required, then she cannot give consent. Say for example, she is victim of sexual assault and she is bleeding and we have to go for stitch. Then she can give consent for examination. Sorry. But she cannot give consent for surgery. So for that, consent of guardian is required.
So one doubt regarding consent for surgery. Sorry, sir.
Sir is there, Dr. Rijesh. Yeah,
Yeah,
please go ahead.
so before the surgery, we usually have a consent on form for implying the place where we put the incision and all. So once we are going through the surgery, we may change the incision site, or we may be planning for laparoscopic surgery. We may show the incision site as laparoscopic sites, trocar sites for consent before surgery, and we may change over that to an open surgery, and the incision may be different. So in that case, patient will be under anesthesia. Are we supposed to get a change of incision picture and get it signed from the bystanders, or is it okay to do it after surgery?
There are two situations. It is very clear when consent is already given for specific surgery and we have to switch over to another surgery, then in eye of law, fresh consent is required. But it is always advisable whenever you are going for laparoscopy, then in the consent form it should be mentioned that in any given situation, if laparoscopic surgery becomes difficult one and we have to switch over to laparotomy, then patient should have given consent for that also. So prior consent is very much required. If we have to go beyond the scope of consent given, if it is life saving, then only we can cross that scope of consent given by patient. Otherwise, fresh consent is required. Say, for example, if you have planned for diagnostic laparoscopy, it is a case of infertility. And if you see bilateral big ovary with PCOD, and you go for ovarian drilling, for which consent is not taken, then it cannot be pardoned. Because in one of the cases it happened. It was case of primary infertility. She was subjected for diagnostic laparoscopy only. But when scope was put, it was found to be a big ovary bilateral, and surgeon went with bilateral ovarian drilling also. Case was filed, and in that very case, compensation was awarded in favor of patient. So, unless it is life saving, you cannot go beyond the scope of consent given.
So
Yes,
one
next.
more doubt. One more
Yes.
doubt regarding the consent from the minor. Suppose we often get POXO cases. They won't be accompanied by any of their relatives, brought by the
Yes.
sometimes the police. And for the examination, do you have to take a consent from their immediate relative for examination of the victim in a
No,
POXO?
no. If I mentioned, if she is more than 12 years, she
Yeah.
can give consent for examination.
Okay.
But during examination, if we find that some intervention is required and some sedation or anesthesia is required, then she is not competent to give consent for the same. In this situation, we have to go with consent from a guardian. Whosoever has brought the patient, is not that guardian should be her mother or father or relative. If, for example, from school teacher has brought the child for examination in this type of situation, then school teacher can also give consent. If at all we have to go for surgical intervention.
Okay, thank you, sir.
Thank you, sir. Now, I would like to introduce Kavita ma'am. She's already started the question. She's a senior consultant of gynae fertility laparoscopy at Kattanam Medical Center, Kattanam, Kayamkulam, Kerala. She's a senior consultant laparoscopist and she has studied from Thiruvananthapuram, done her MS and DNB and Masters in Cosmetic Gynecology. So, welcome, Kavita ma'am, and over to you. And my request, please ask one question at a time.
Okay, ma'am. Am I audible?
Yes, ma'am. Welcome.
Yes, sir. Good evening, sir. So I wanted to ask you whether a mentally challenged person can give consent.
No. In this case, consent of guardian is required.
Consent of guardian is required.
Yes.
Whatever age.
If she,
Okay,
and
sir.
she mentally challenged, irrespective of her age, consent
Okay,
of
sir.
guardian is required.
So and then my next question is: can deaf and dumb person can give consent?
If deaf and dumb person can be explained through translator or through that sign, etc., if we know, then and if she has understood, then she can give consent. If she is major and otherwise mentally sound. Otherwise, consent of guardian is required in this situation also.
Okay, sir. My next question is: who will give consent in an emergency situation?
In emergency, no consent is required. But burden of proof will be on our shoulder to prove that it was emergency and whatever we did, it was to save life of patient. So if we can prove that it was an emergency, we can proceed accordingly without consent also.
Okay,
So
sir.
is it essential for a medical superintendent to give consent in case of patient who has no bystanders in case of
Yes.
emergencies?
So any person who guards the patient can give consent. So if person has come alone, then fine. If person is brought by another person who is also minor, then he or she cannot give consent. So in this situation, head of the unit, head of the department, head of the institution can also give consent. And in this situation, if she is minor and if she is victim of a sexual offense, we have to inform police. In this situation, even police can give also consent.
Okay, sir. So can you explain, sir, what is an informed consent?
I mentioned prior also, informed consent means patient should have knowledge about your treatment plan or surgery or procedure with all its benefits and its probable side effects. So patient should have knowledge.
Okay, sir. Thank you, sir.
Thank you. Welcome.
Next, we have Dr. Asha Nath, ma'am. She's professor. She's Department of Gynae, Government Medical College, Kottayam. Over to you, ma'am. Asha Nath, ma'am.
Thank you, Master Madam. At the outset, I express my sincere thanks to Professor MC Patel, sir, and my HOD, Beena Kumari, madam, for making me a part of this Happy Learning series. So, sir, my question is, does the Supreme Court expect us to talk about all the possible complications?
So in that case, just we mentioned prior, Samira Kohli versus Prabha Manchanda, Supreme Court has very specifically mentioned that no need to explain about very remote complication. Due to that, patient is frightened and patient is not ready to give consent. So we have to explain about possible complications which are immediate and which are major one. So court has very specifically mentioned in Supreme Court. But in this situation, when we explain about the probable complication, we have to balance. Patient should not be frightened in that way. Patient should not be scared when we explain everything about complication. But we have to explain all the probable complications which are major one, which could be immediate, which could be remote also. But remote and rare complication should not be explained, or if we have not explained, it doesn't matter.
So in our Kerala, most of the people are too much literate, and so whether they will create any problem that the doctor hasn't explained, such they would have known such a complication like that. So is it safe from our side to?
Solution I will give. You have to simply visit Foxy website, and on Foxy website, Foxy Uniform Consent is the title, and if you go with that title, you will receive 30 different consent. 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. Say, for example, cesarean section, hysterectomy, abdominal, vaginal, endoscopy, termination of pregnancy, medical method, surgical method, consent for anesthesia, consent for normal labor, consent for osteotomy, and so on. So 30 consents are there. And if you go with any one consent, you will appreciate which kind of pain we have taken. We have taken utmost care. So you are not to worry. If you go with consent for cesarean section, you will appreciate. We have mentioned each and everything in a very decent manner. Patient will not be frightened, and then also everything will be covered. Say, for example, possibility of scar pregnancy in future. This is also, of course, remote and rare possibility, but it is there. So we have mentioned that also, but in a decent manner. So patient is not frightened or scared. So you have to simply visit that website, and you can download and use in your day-to-day practice. Because at the time of deciding this and writing this consent, we had a discussion for one word or one line for hours together. And we had a collaboration with Law University of Maharashtra. So learned advocates were also in our panel at the time of discussion. And one of our doctor friend who was at National Commission in CPA, Dr. Kantikar from Karnataka, now he is retired from that board. So he was also invited to give her inputs, his inputs. So after that, we have prepared all those consents, and these all consents are available on Foxy website.
Okay, sir. Thank you.
Next, we have Dr. Bessie Binu Sam, who is also Professor, Government Medical College, Kottayam. Her hobbies are baking, gardening, and photography. And the video she sent me of all her cakes, you just have to look at them and taste them. Next, you go to Kerala, don't miss Madam's cakes. So over to you, Bessie ma'am.
Thank you, sir. Thank you, madam.
So,
Thank you, sir.
So Bina Kumari and Bessie madam will have to invite me for Kottayam.
Of course, sir. Of course. Sir, my question is, if patient or relatives refuses to give consent, what to do?
So we have to explain patient about importance of that surgery or procedure or our treatment plan, and we have to explain her importance. And if we refuse, then we have to go for negative consent, because there is role of negative consent also. And we have to explain about risk of refusal of that consent. If we do not go with that procedure, or if we do not go with that surgery, which are the probable complications likely to occur. So if we have explained, and we have to take signature on negative consent also, that I was explained about this, but I am not ready to give consent. So if we have taken consent like this, then it will be a good defense in our favor.
So, is there any role for negative consent, sir?
Yes, I mentioned.
Oh, yes, sir. Sir, if they refuses for negative consent, what will we do?
Yes, this is also very common situation. Many times we advise that cesarean section is required. Then patient is not ready to give consent at that point of time, or she will discuss with relative, and relative will say her husband is not there. We have informed him he is coming. When he will come, we will give consent. And many a time that precious time is not in favor of patient, because if it is an acute emergency and we have to go straightway for cesarean section, and patient relatives are not ready to give consent. So in this situation, negative consent is very much required. If patient and patient's relative are not ready to give negative consent also, then in this situation we have to mention in case paper that it was explained to the patient and patient party. They were not ready to give consent. They were not ready to give negative consent. And if possible, any co-patient or any visitor of hospital can give consent that it was explained before us about importance of that surgery or procedure, and patient were not ready to give consent, and they were not ready to give negative consent also. So this saves in a court of law as per any litigation is concerned. But at the same time, we should be careful. Whosoever the person signs that document, third party, that is co-patient or any visitor, we have to take all the details of that very person, and we have to explain him or her that if at all required, he should be ready to come to court in our favor to give evidence that it was explained before me and patient party has refused.
Okay, thank you, sir.
Yes, welcome, Kumar.
Thank you, sir.
So Dr. Kumar Gopal, sir, he is working as consultant gynae at Gaurisha Hospital, Trivandrum since 2012. He is a member of RCOG, and he works in a department that has more than 1,000 deliveries a year. My God. And how you got the time to sit here, sir, we are really gratified. And he's an avid tennis player. You can
Good.
have a look. So, welcome, sir.
Thank you. So the first question is, can consent be taken by assistant doctor or staff?
Yes, anybody can take consent. It is not necessary that consent is to be taken by a doctor who is going to operate or who is going to go for any procedure. But whatever written in that very document, each and every point should be explained to the patient, and then after they can get signature from patient and one relative as a witness.
Second question is, can there be a common consent for diagnostic and operative procedures together?
Yes, just I mentioned prior also, if you have planned diagnostic laparoscopy with additional surgery, then we can go with common consent. Say for example, cesarean section with bilateral tubal ligation, cesarean section with myomectomy, hysterectomy with bilateral salpingectomy, hysterectomy with bilateral salpingo-oophorectomy. So if we have taken consent, common consent, then we can do all this surgery. But if consent is not given, say for example, at the time of cesarean section, we feel that next pregnancy could be dangerous for that very patient. Even then, if consent is not given for tubal ligation, we cannot proceed for tubal ligation, because it is not immediate danger to life of patient. Patient is not going to be pregnant very next day. So if consent is not given for that, we cannot go beyond the scope of consent given. But common consent can be given prior surgery.
Next question is, can there be a common consent for particular surgical procedures and additional procedures?
As I mentioned, cesarean section with myomectomy, cesarean section with tubal ligation, hysterectomy with salpingectomy, salpingo-oophorectomy. Many a time, hysterectomy with ovarian cyst, or any cyst removal also. So we can go with this kind of two surgery at a time with common consent.
Sir, but if ovarian cyst is detected at the time of cesarean, which was not detected prior, in such a case, could we do a...
If prior consent is not taken, then better not to touch. But if we can prove that it is immediate necessary to save life of patient, then we can remove.
Thank you, sir.
One more example I would like to say. Say, for example, if we have not taken consent for myomectomy during cesarean section, we cannot remove myoma. But if any myoma is on the way to deliver baby, then we can very well remove that myoma and we can deliver baby, even if patient has not given consent for myomectomy.
Thank you, sir.
Next, we have Dr. Kala Pramod ma'am. He is an MD Gynae professor at Sat Government Medical College at Thiruvananthapuram. He is currently the secretary of Trivandrum Obstetric Gynec Society. Interest is high-risk obstetrics, adolescent health, and medical education. Kala ma'am, over to you.
Thank you, MC Patel sir, for giving our society an opportunity to participate in this wonderful panel. So my first question to you is, can we allow attendees during surgery?
Of course, we can allow, but with prior consent of patient. If patient has not given consent, if patient is not agree, we cannot allow.
Okay, okay, sir. Next is we know that now we cannot play live workshops, we cannot live surgical workshop, we cannot conduct. But can we record the surgery or procedure and can we display it during a teaching class, during a CME or a workshop? Is it possible, sir?
With prior consent, we can record surgery or procedure. We can display also with prior consent. But at the time of display, personal identity of patient should not be revealed.
Okay, so before the surgery, we are planning to record, you have to take the consent for that also.
We have to take consent to allow attendee for recording and display that recording during CME, workshop, conferences, or in teaching class.
The next question.
As far as live relay is concerned, just to mention, one case happened in Supreme Court, and Supreme Court has referred that part to National Medical Council. That can live surgery be allowed, because allegation was due to this live surgery in conferences, etc. There is compromise on part of quality of surgery with patient, was the allegation. So as on today, National Medical Commission has banned to relay live surgery during workshop or conferences or so. But we can record that very surgery, and recording can be shown during conferences or workshop with prior consent of patient. But live relay of surgery is not allowed as on today, it is banned. So till final disposal of that very case, we will have to wait.
Okay, thank you, sir. The next question is, usually we take a consent for any surgery and it includes a consent for anesthesia, or whether we should take a separate consent for anesthesia. Is it needed?
Separate. So a court has very specifically mentioned that separate consent for anesthesia should be taken, because surgery involves risk and anesthesia involves additional risk. So all the risk involved in that very anesthesia, type of anesthesia, probable side effect, we have to explain. And anesthesiologist is the best person to explain everything. So it should be explained to the patient, and consent for anesthesia should be taken separately. And
so the anesthetist should explain his complications and the separate consent is needed. Okay, sir.
And I mentioned prior also, it is available on Foxy website. We have prepared consent for anesthesia also. And for that, we have taken help from anesthesiologists, that which kind of probable complication we should mention at the time of consent, type of anesthesia. So we have prepared that consent for anesthesia in a very decent manner. You go through and you will appreciate it.
Okay, the next question, sir. Do you need a separate consent for blood transfusion also? That means for
Yes.
the surgery, sometimes in the case of PPH, as an emergency, we may issue a lot of blood and blood products. So do you have to immediately go and take the consent for that? Or in the initial part itself, when the patient is admitted, can we take sometimes blood products may be needed? So that is a consent is enough like that.
So, in one of the cases, Supreme Court has mentioned that surgery involves risk and blood transfusion involves additional risk. So separate consent for blood transfusion is required. Because in one of the cases what happened, it was third cesarean section and 2 units of blood already transfused during cesarean section, and during third unit, patient had some adverse reaction and case was filed. That consent for blood transfusion was not taken and case was decided against doctor. In that very case, court came up with guideline that separate consent for blood transfusion is required.
So in an emergency, when the patient is bleeding, he
I
can.
mentioned prior also, if it is an emergency, it is pardon.
Yeah.
But burden of proof is on your shoulder to prove. But it is always better to mention. We have prepared consent for normal labor also. And in that also we have mentioned.
Okay.
In spite of utmost care and caution, it is not certain that how much bleeding she will have. And in this situation, in few of the condition, blood transfusion may also be required. And for that, we have been explained and we give consent. So if we have mentioned like this, then it's fine. But if it is planned prior, as far as blood transfusion is concerned, then separate consent is must.
Okay, sir. Thank you. Thank you for all the answers and also for making me a part of this wonderful panel. Thank you.
Welcome.
Thank you, sir. Now we have Dr. Reggie Mohan.
Hello. Can you hear me?
Yes, Dr. Reggie. Yes, Dr. Reggie.
Hi, Asha madam. Hi, sir.
Hello.
Welcome.
So, sir, he is a very, 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 very active person, also a member of Food Drug Committee, and he has a short-term fellowship in reproductive medicine department, and he is assistant professor, Department of Reproductive Medicine and Surgery, SAT Hospital, Government Medical College, Thiruvananthapuram. So, welcome. Over to you.
Thank you, ma'am.
Over to you, Dr. Reggie.
So very healthy and very helpful discussions going on. My question to MC Patel sir is a return consent mandatory? And can it be taken in a pre-printed form, or we have to ask either the relatives or the patient to write in their own handwriting in their own language? 3 questions, sir. Written consent, whether it is pre-printed form, is it validity is there? So whether it can be taken in her own language, then fourth in what about the language?
So as far as written consent part is concerned, by law there are 3 conditions in which written consent is very much mandatory. One is organ transplantation. In organ transplantation, written consent is mandatory. Under PCPNDT Act, sonography of antenatal patient, written consent is mandatory. And in case of medical termination of pregnancy, under MTP Act 1971, written consent is mandatory. So these 3 are conditions where written consent is mandatory. Otherwise, we
Sir,
can
sonography, can you explain once more? Sonography?
Antenatal patient sonography under PCPNDT Act. Consent of patient is mandatory. Under
before doing sonography.
Before going for sonography. So otherwise we can go with oral consent, but burden of proof will be on our shoulder to prove that we had explained and patient has given us consent. And many times patient may go hostile. So though it is not mandatory, other than these 3 conditions, it is always advisable to go for written consent. As far as pre-printed form is concerned, I would like to mention very famous case which happened in past only. RG Stone Hospital versus Vinod Khanna. Vinod Khanna was a HIV positive patient. He had some urological problem, and so many hospitals refuses him to treat and operate due to his HIV status. RG Stone Hospital became ready. He was admitted. Surgery was done. Everything was fine. He was discharged in due time. There was no complication. Even then, patient filed a complaint against RG Stone Hospital that my consent was taken on pre-printed form, and it means it is a unfair trade practice. So case was filed, and in National Commission, case was decided against hospital, and rupees 10 lakhs was awarded as a compensation to that very patient. RG Stone Hospital was ready to pay that compensation, but at that point of time, we were preparing this uniform consent. So on Foxy level, we approached RG Stone Hospital. One of our colleague, Dr. Nikhil Datar, who was in with me for preparing those consent, and RG Stone Hospital were convinced to go for appeal, challenging that very judgment. Because if it was not challenged, then it was very much compulsory that we were not able to use pre-printed form. Either patient would have to write, or surgeon, or any of our staff. So it would have been very troublesome for us in future. So we could convince RG Stone Hospital, and appeal is filed. At the time of tabling that very appeal, we could convince Honorable Higher Fora that what is unfair trade practice. If we go by law and in literature, then unfair trade practice means to do anything in unfair way to promote business. Now in our medical practice, if we take consent in pre-printed form, if we take consent by patient's own handwriting, if we take consent by handwriting by surgeon or staff, does it enhance our practice? And court was convinced. So our appeal is filed. We are waiting for final judgment, and we are quite hopeful that judgment will be in our favor. Till then, it is stay, we can use pre-printed form also. As far as English or vernacular language is concerned, it is preferable in vernacular language or language which patient can understand. But if it is pre-printed in English, then at the end of that very consent, patient should have written in her own handwriting that whatever written above was explained to me in language which I can understand, and I will answer all my questions and query, and then after I have signed this document. Then even if it is printed in English and patient doesn't know English, it will do. Or if there is translator who can translate that consent to the patient in language which patient can understand, and after the signature of patient, signature of that translator will also be there. Translator will write that whatever written above was translated in language which patient can understand by me, and then after patient has signed the document. So if we have done like this, then it is very much valid.
Sir, can I ask one more question?
Yes,
so recently,
yes.
one case was referred by National Medical Commission to me. Actually, what they found was it was a triplet pregnancy, and they were advised reduction, fetal reduction. But that time, the couples refused. But either the patient or the consultant didn't sign the refusal form. Okay, and finally, all the babies were actually IUD and premature death and all those things. Those couple went to a court and filed a case against the doctor. But what they found out was the refusal was not signed by the patient or by the consultant. So is it necessary whenever we are explaining something? So is it necessary to get the written signature of the patient and the consultant?
Yes. So patient should have signed that very negative consent also, that we were explained about importance of fetal reduction, but we are not ready to give consent for fetal reduction, and we are very happily agreed to continue with the pregnancy with all its probable complications which are explained to us. So if we have explained like this and if patient has signed, it is good. If patient is not signing, then we have to mention in our case paper that everything was explained to the patient and patient is not ready to give consent. patient is also not ready to give negative consent. And just I mentioned prior also, if any third person or any co-patient signs that very document that in our presence it was explained and patient didn't give consent, then it becomes good defense in our favor.
Thank you, sir. Thank you very much.
And as far as last question, who should sign the consent? So naturally patient, two witnesses, one in favor of patient and one in favor of hospital, and doctor or person who has explained about all this counseling and who has taken consent should also sign the document. Because just I mentioned prior, when we take any patient to treat, it becomes a contract between patient and ourselves. And under Indian Contract Act, unless all the party involved in contract signs the document, document is not valid. So consent paper should also be signed by doctor. Yes, any other question, Reggie?
Dr. Rajesh, over to you for your next question. Dr. Rajesh?
Yes, madam. Actually, this is one thing. We usually take consent for hysterectomy. Then we'll usually do either hysterectomy with BSO or we'll put just TH. So when we are doing salpingectomy also with hysterectomy, even if we are retaining the ovary, is it prudent to take consent for salpingectomy? Is it necessary or is it?
Prior consent is must. If we
Even
have,
though we are keeping the ovary, just removing the tubes.
At the time of taking consent, we have to explain everything. We are going to go for hysterectomy, whether vaginal, abdominal, or endoscopy. And at the same time, if we are going to preserve ovaries, and if we are going to go for salpingectomy bilaterally or unilateral, whichever the case may be, then we have to mention at the time of consent that patient has given, I am ready to give my consent to go for bilateral salpingectomy. So it is very much required. If we have not taken consent for salpingectomy, we cannot do salpingectomy.
Yeah. The
Same
second one is,
method.
yeah, when if we are seeing a fibroid which was maybe previously detected or something, maybe subserosal, we think it is removable, and the patient has only given consent for cesarean section. Can we go on with the myomectomy?
No.
Can we go by taking the consent of the bystanders in between surgery?
No. If you go with this uniform consent, in those very consent, we have prepared consent in two parts. Part one is information and part two is undertaking. In that undertaking, we have mentioned one para that if any unanticipated or emergency situation happens, and if doctor feels that he has to proceed consent given beyond the scope of consent given by me, he will discuss with my relative, Mr. or Mrs. So-and-so, who is waiting outside operation theater. And if they give consent, it will be as good as consent given by me. If patient has given consent like this, then we can discuss that situation with that very person. And if that very person gives consent, then we can very well proceed accordingly. One more para also we have mentioned, added. In that very situation, patient has written like this. If any unprecedented or unanticipated situation happens, and if it is very necessary or in good faith of me, and if the doctor has to go beyond the scope of consent given by me, I give my authority to my doctor to proceed accordingly. If patient is given consent like this, then you can go beyond the scope of consent given by patient.
Okay, sir. And suppose sometimes we take a patient for emergency cesarean section, and we might have taken only the consent for cesarean section, and the baby might be we may have taken for fetal distress or something. Baby might be fine when we do cesarean section, and when we show the baby to the bystanders, they may say we want a sterilization if the baby is okay. So is there a possibility of doing tubal ligation during cesarean section if prior consent is not taken and in between the bystanders ask for that?
So it is very clear, if consent is given for tubal ligation, if we can very well go with tubal ligation if conditions favors. If we have not been given consent for tubal ligation, we cannot. If consent is given for tubal ligation, and if we feel that baby is premature, low weight, and risky one, it is not necessary that consent is given so that we have to go for tubal ligation. We can postpone tubal ligation. But whatever we do in good faith of patient is always pardoned in court of law. Because court interprets in what way? In that very situation. What any prudent doctor would decide whether he will go for tubal ligation or whether he will postpone. Naturally, any prudent gynecologist will postpone. If baby is premature, baby is low weight, and if risk involved as far as baby part is concerned. Even if consent is given for tubal ligation, any prudent doctor will postpone that tubal ligation. If you postpone in this situation, you are pardoned in court of.
Thank you.
Sir, can I ask a question?
Yes, yes.
Sir, sometimes the patient will say whether it's a boy, I will sterilize, and it's a girl, I don't want sterilization like that. So, since the patient is in regional anesthesia, can we take a consent during the surgery?
No. If she has given conditional consent, we will say that if I deliver boy, I am ready to go for tubal ligation. If baby is healthy and if you feel that everything is fine, you can very well go with tubal ligation because she has given you consent. If she delivers female baby, then she has not given you consent for tubal ligation in this situation. You cannot go.
Okay, okay, sir.
Thank you, sir. Sir, requesting you to speed up a little. We are
yes,
losing our audience as well. And we have two people more. Dr. Kalpana, ma'am, over to you, ma'am. I've already introduced you before. Thank you so much for the effort you put in for this webinar, ma'am.
Thank you.
Over to you.
Could you hear me, ma'am?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Thank you, sir. Thank you, Patil, sir. I have been a great fan of yours, following your classes, and also any conference, some medical legal seminar is going, it will be yours. You explain in very simple terms. My question is is consent of spouse is required for sterilization? Because most of the time the spouse won't be in station, or he will be not even reachable by phone. So if patient has given or if a relative is given consent, is it enough, sir?
So in this situation, there are two points. In one of the cases, Supreme Court has very specifically mentioned then when you are going to go for full stop on reproductive capacity of that very couple, spouse should be taken into consideration and consent of spouse should be taken. But at the same time, there are circular on part of state government in so many states that consent of spouse is not required at the time of female sterilization operation. So if you follow that guideline on part of state government, then also you are pardoned, but not to end up into any kind of social problem, because many a time legally you are saved, but socially husband will come that you didn't take my consent, you didn't inform me, how you dare to go for sterilization operation with my wife. So these are some social issues. So not to end up into that, so at least he should be taken into consideration. If he is not available, if he is available on phone, we can discuss with him in phone and we can record that phone conversation. Or on video conferencing also we can discuss and we can take consent. Because female sterilization operation is not an emergency operation. And if we are planning with cesarean section prior, then prior this type of conversation can be done. And not to end up into any social problem, we should take into consideration.
Like he has come in one of his AMC visit and he has given consent. You can go with sterilization during surgery or something like that. Is it enough, sir? Or we must take? Yeah.
When he is major, when he is mentally sound and he gives consent, that it means he is ready. If her spouse is willing to go for sterilization operation, he is also ready.
Okay. Another question is consent required for obstetric sonography?
As I mentioned prior also, it is very much mandated.
Okay, sir. Okay,
As I mentioned, 3 conditions, they are mandatory by law. This is one of them. Obstetric sonography, prior consent is must,
Yes.
mandatory.
Okay. Thank you, sir. Thanks a lot, sir.
So last but not least, we have Dr. N.R. Reena. She is a consultant gynecologist at Kerala Government Health Service Department. She is the past secretary of Kollam Society, practical obstetric committee member, and president of KGMOA Kollam, state managing editor of KGMOA 2324. Welcome, Reena ma'am. Sir, she writes a vlog in Malayalam. It's available on YouTube. So I cannot read what is written. Stri Sokyam vlog. So this is ma'am's blog. Over to you, ma'am.
Okay, thank you. Thank you, Patel sir, for this wonderful opportunity. And my first question is, who can give consent for MTP?
When patient is major and mentally sound, only and only patient can give consent for termination of pregnancy. If she is minor, if she is mentally challenged, then consent of guardian is required.
Okay, sir. If they are giving consent for MTP, instead of Form C, can one take consent in usual manner as in other surgeries?
No, we have to, in Form C, it is a mandatory form. It is prescribed form under MTP Act 1971. So we have to go with consent in Form C only. But in Form C, it is not informed consent, because in Form C, it is simply mentioned that I give my consent to terminate my pregnancy. That's all. So if we have to go for informed consent also, so we will go with two consent, one informed consent and one consent in Form C. So consent taken in any other manner, that is informed consent, cannot replace consent to be taken in Form C. So Form C consent is very much mandatory, and informed consent is also advised.
So well, we have to take two consents, one in Form C and other informed consent. Okay.
And
sir.
again, it is available on Foxy website. Medical termination of pregnancy by medical method, it is separate consent. For by surgical method, it is separate consent. We have prepared and it is available on Foxy website.
Okay, sir. Okay. Does consent of spouse required for MTP?
No, no. Under MTP Act, no consent of spouse is required.
Not at all required. And does consent require at the time of advising for HIV testing?
So it is not mandatory, but it is guideline on part of NACO and WHO that patients should be explained about importance of that HIV testing, and consent should be taken.
Proper counseling we are giving
Proper
before
counseling.
checking. Yes. Okay. And is video consent valid?
Yes, video consent is also valid, but I always say video counseling and consent is double-edged sword. Because if you miss any important point at the time of video counseling, and prosecution, smart advocate on part of prosecution, he will mention that this important point you didn't discuss, and that is why we gave consent. So this consent is not valid. So even if you go with video counseling, video consent, printed consent form should be on your table, and you will see that no important point is missed at the time of discussing about that very procedure or surgery. And video counseling and consent is very much accepted evidence in court of law.
Okay, sir. One more question I have, sir. If a minor girl coming for MTP, is it police giving police intimation is required, no, sir? But
Yes.
is it required to get a consent from the parent or guardian for giving police intimation in such cases?
No. To intimate police, willingness on part of patient or patient's relative not required. Because under POXO Act, once he is minor, you are under obligation to inform police whether you are going to terminate pregnancy or not. But once you come to know that she is minor, she is pregnant, or she is victim of sexual offense, even if she is not pregnant, then also you have to inform police.
So in recent Supreme Court verdict, it was stated that we have to take consent from the parents, or we have to give police intimation in an anonymized manner.
As far as examination is concerned, we have to go with consent only. If patient is more than 12 years, she can give consent for examination. Otherwise, guardian can give consent for examination. But to report police, no consent or no willingness on part of patient or patient relative is required. We have to. It is compulsory under section 19 of POXO Act, and if we fail that under section 20 and 21, there is a imprisonment of 6 months, and that we cannot afford. That is why we have to inform.
Is it required to keep an anonymized register for these minor MTP cases if they are not willing to reveal their identity?
For IMTP, we have to enter all this detail of any patient, whether minor, whether major, in MTP register. That is Form 3. It is called MTP register or Form 3. And that Form 3 or MTP register, it confidential and secret document. So it is no separate register for minor. It's the same register we have to maintain.
Sir, but case sheet is not confidential. Any staff or anybody coming to the hospital can see.
MTP register cannot be open to anybody. It should be. Let me complete.
No, I'm not saying about MTP register, but case sheet. Case sheet is any doctor or any staff can see the case sheet.
So
is it needed
up to OPD register, name, age, address, staff or one has maintained. Once you examine patient and once you come to know that she is victim of sexual offense, then after all this matter concern, that we have to keep everything confidential. If we plan to go for termination of pregnancy in major or in minor, at the time of considering MTP and when we enter all the details of that very patient in MTP register, then after all the correspondence will be with number which is given to that very patient in that MTP register. Then after in discharge card, in OT register or in any other correspondence, you will mention number only and no name. And this register is under your custody. It is not open for any person or any visitor or any staff or a hospital to inspect. It is confidential document.
Sir, what about case sheet? No need to write her name in that case sheet.
Many up to when we decide to go for termination pregnancy, it is a common case. Up to that, there is no problem. But then after any correspondence, we will go with number only. So we can prepare one new case, fresh case with number.
Okay. Okay, sir. Thank you, sir.
Yes, Asha.
Thank you, sir. So we have come to the end of the program, sir. And I would like to... So would you like to say a few words for your vote? And then I would like to end the session, requesting everyone, if you would please put on your cameras, we could take a group photo. Requesting everyone, please put on your videos.
It is my humble appeal to endorse my candidature for post of President Foxy election year 2024. Considering my seniority, sincerity, dedicated work in Foxy since years together, and easily availability for any Foxian friends in any given odd medical legal crisis, if you consider that I can lead this association in a better way and I can be much more helpful in that capacity to each and every Foxian, please consider my candidature and please cast your precious vote in my favor, and please say other members, other friends to cast their votes in my favor. Thank you for the same. And at the same time, Dr. Asha Jain is also contesting for Chairperson Food, Drug and Medical Surgical Equipment Committee. And for that, society has to vote. So my election would be from 1st to 10 August. And for Asha Jain, madam, from 16 August to 25th August. So society will have to vote. Society less than 200 membership, 1 vote. More than 200 membership, 2 votes. So I request on her behalf to vote for her also. She is very sincere worker, hard working lady. She is working in this series since long with me, so I can give all the surety as far as her sincerity and dedication in future if she is elected that very post. So my humble appeal for myself and for Dr. Asha Ji.
Namaskar, thank you so much for being here. Today, this Kerala meet has been really successful. We have had more than 350 people logging in. So thank you so much. All of you have really made a great effort. So I thank you from the bottom of my heart for being here. Thank you, sir, for joining all of us. And please vote for me and for sir. So sir has become so senior. He was a chairperson many years back. Actually, it's more than 100 members, there are 2 votes. Less than 100 members, there's 1 vote. Please do vote for me. Thank you so much for being here, all respected guests, speakers, chairpersons, panelists. Thank you so much. Thank you, Dr. Rajesh, and thank you, Dr. Kalpana ma'am, for making all the effort to make this program successful. Thank you so much.
Today we had Society Adur, Alappi, Kottayam, Kollam and Trivandrum, and one more episode with Kerala few 5 society would be on 2nd of July. And again, we will be meeting on this platform with different topic and with a different discussion. So welcome all the delegates again in that very episode also. Thank you. Thank you very much.
Patel, Dr. Asha.
Thank you so much. Yes, ma'am.
Thank you, madam. Thank you.
Thank you. May I end the session, please?
Oh, yes.
Thank you. Namaskar. Shubh Ratri. Good night.
Thank you, ma'am.